Hello and welcome to this episode of the Bendy Strong podcast. So today I've got my rehab guy here, Shant, and he is great with rehab and he's become very specialised interest in Ehlers-Danlos'er and hypermobility as well. So he's who I send a lot of the people with hEDS and hypermobility to, who go beyond my understanding of strength training and how to fix people. If I don't know how to fix it, I send it to Shant. So we've got a couple of things that we're going to talk about today. One of the things that we wanted to go over was, we were talking about this recently. I had this experience and I'd actually also had a client or a member of my Bendy Strong program who'd had this experience with the sacroiliac joint subluxing after doing an exercise. So this person said to me, my SIJ subluxes after I do deadlifts. And I thought, oh, that sounds really awful. And then, of course, it happened to me, so I got to experience, and then I mentioned it to Shant, and he's had a client who's experienced it recently. So we just wanted to run through, we kind of separately came up with a protocol that ended up being quite similar. Like the protocol I came up for myself and the protocol he came up with for his client ended up looking quite similar. So we wanted to talk about the similarities in our approaches, the differences, and how that works out. So we'll get into this in a second. Just before we do, a quick disclaimer. Nothing we're talking about here is medical advice. This is just a discussion for educational purposes. Yep. Make sure you've got clearance to exercise before you exercise. If you're going to start exercising, we highly recommend doing it under supervision. And of course, make sure you're cleared as well before exercising.
Absolutely. Yep.
Awesome. And if you want to get cleared for exercise for your joints, if you've got any joint issues, you can always see Shant to get guidance if you're not sure where to start, or if you've got pains that you are having trouble working through, etc. So let's get into it. So I guess I'll talk about from my experience. I had this happen to me recently. Now it's probably important to say I've also been going through some flares recently. I've had some personal stress. Things were going really, really well for me for a while. I was on a mast cell stabilizing, well, I still am on a mast cell stabilizing medication, and things were smooth sailing. And then I had some personal stress happen that really just took over everything. And I had ongoing migraines, fatigue, more food intolerances, and an increase in joint subluxations as well, all as part of that flare. So I was feeling pretty good at this point. I went into the gym and I was having a really good day. I did some front squats. I didn't do anything crazy. And especially compared to, I've been training for a long time. A while ago, if I'd done this, I would have just walked away and nothing would have happened at all. But I went in, I did the front squats. Then what happened was my back felt like, it wasn't bad pain, it was just regular muscle soreness that you get after training. And it was a bit like, oh, okay, that maybe I pushed a little bit hard, but that's okay. But usually what we see with muscle soreness, DOMS, delayed onset muscle soreness, is you might feel it a little bit on the day or the day after, but usually where it peaks is day 2. So if I train on Monday, Tuesday I'll start to get a little bit sore, Wednesday I'll be really sore, but by the end of Wednesday, it's usually starting to taper back down. But what I found was it followed that pattern. It was a bit sore the next day. My muscles were a lot sore than the day after, but it never tapered down. It just sort of continued. It's like someone turned the volume dial up and up and up. And then about 5 days or 6 days later, I woke up and I couldn't stand up straight. I believe my SIJ was subluxed. I didn't have a doctor or physio to verify it, but
you're very familiar with that feeling.
Yeah, it's that incapacitated feeling. Usually that's how I know it's a subluxation, when I feel the joint, it's incapacitated. I also couldn't stand up straight. And when I looked in the mirror from the side standing up straight, I was like, there's something really not right in this position. And then days after, I did get to see my doctor and he felt around. He's like, this area is very inflamed. So I suspect that's what happened. And that scared me a lot, because whenever you get something new like this, it's sort of like a new level's unlocked with the Ehlers-Danlos'er. So I haven't experienced that before. Now I'm experiencing it. That is actually scary to know what might happen. But I kind of came up with a bit of an approach, and that's what we're going to talk about, how I approached it, how you approached it with your client who had a very similar thing happen.
Yeah.
And the approach was basically, well, should we talk about your client's experience first, then we'll talk about the approach?
Yeah, 100%.
Yeah, okay, over to you. So that was my experience. So I had the subluxation, and then it took a couple of weeks to get through that because I was flared up, and then it was even more flared, and then you know how life happens. It's never smooth sailing with EDS. But then the next time I went in, I really wanted to do deadlifts. And since then, I've done like 3 or 4 deadlift sessions, and I've lifted decently heavy, and I haven't had this issue arise since implementing this. And it might just be that I was less inflamed in these other sessions, but hopefully it's my approach that's made a difference. But over to you, Shant, to tell your client's experience.
So before we get back to my client, I think let's establish a bit of a history, right? I met you in 2020. I think I was doing a seminar with Andrew Locke over in Sydney, and you're prepping for your IFBB comp, the wellness comp. And the primary thing you wanted to see me for was the SIJ dysfunction, right? So you're very familiar with SIJ dysfunction. And one of the first things that we first established that it is a true SIJ dysfunction or it's a true SIJ injury, right? So I think that's one thing that we need to be very, very mindful of, that we understand the origin of what that problem is, because it can be quite misdiagnosed. Second part.
Just to interrupt, sorry. When we say true, just for people who don't have the context of what that means, what's the difference between true and so-called false?
So one of the most common way SIJ dysfunction or injury gets diagnosed is through location-based diagnosis. Now, I'm not a fan of the word diagnosis either, because diagnosis, it just means I have come to a conclusion about a particular set of information, right? So the interpretation can be erroneous sometimes. But the main point is location-based diagnoses generally tend to be more incorrect than correct. So if I poke into that SIJ location, those little dimples that you have in your low back, if I push in that location and you get pain, generally it is considered that it's SIJ dysfunction, or it's an SIJ injury. Right?
So you're saying location based on the pain, the location of the pain.
It does not necessarily
often ends in
mean
misdiagnosis.
It is, yes. So. And the reason for it's a very busy area, right? All the extensor muscles, meaning if you're bending down and I'm coming up, which is the extension movement, all the muscles that contribute in that movement, they're all inserts in that SIJ location. So it's a very busy joint. There's a lot of things happening in that area. So just focusing on the location alone does not give us all the information necessary, right? So that can lead to misdiagnosis. But the other part of it is also, it's a very busy area there's a nerve roots coming down from underneath that area. So again, if I push into an area that has other physical breakdowns or dysfunctions, it will give us a positive test. But that doesn't necessarily mean that it is an SIJ injury.
Can it also be just because there's so many bones around that area that influence, like the sort of, if there's dysfunctional movement happening a bit further up, that can cause like actual physical pressure from the bones to...
If an area is getting overused, for whatever the dysfunction may be, if I provoke it, I will be able to create pain. And just creating pain doesn't necessarily mean it's a positive test. Right? So that's something we want to be very careful about. That's what I call a true SIJ injury, which is... There are other tests, and I think we did a really long podcast on just SIJ. So I think, we can refer that to people. So there's a lot more in-depth information available on that SIJ injury and the mechanism and the importance, or the, just to have a bit of an appreciation how important that joint is and how busy that joint is and the amount of force that goes through that joint. The amount of forces, that gets produced in that location with all the muscles, it's enough to lift a small car.
So with true and false, then, do you think it's fair to say that a true SIJ problem is the pain is in the SIJ and the dysfunction, whereas with a so-called false SIJ, where it might create a false positive that makes people think it's SIJ but maybe isn't a true SIJ problem, the pain might be in the area but the dysfunction might actually be somewhere else?
Well, we kind of want to see it as reverse engineering, right? So let's say that I have the pain in that SIJ location. And then I do the right biomechanical testing, which involves testing movements, testing functions, testing the articulation or the range of motion and the movement, the active movement. Once I have done all those tests, and there are some very particular type of pain provocation tests that has been proven to be very valid. Once I have done all those things and they're all pointing in the right direction, only then I can say it's a true SIJ. So yes, our starting point is the pain in that location. But we are kind of like moving away from it, and we're looking from the outside in rather than inside out. So we're looking how many pathways that we know to be true that's pointing to that, the diagnosis of SIJ pain or SIJ dysfunction, right?
Yeah.
So once we have established that, this is where precise assessment, individualized assessment is very important, right? So, and it's not exclusive to hEDS or hypermobility, it applies to everyone. Right. So I think that's something we want to be very, very clear about. Like, we need to understand that we're being very specific with our understanding what is contributing to that problem. Otherwise, no matter what approach I take, I'm trying to fix a problem with a completely different tool, and it will never produce the result that we want.
Yeah, it's like my car had problems accelerating and the mechanics misdiagnosed it and just fixed one thing, and then nothing fixed the problem. I still had the problem when I was driving because, sure, they made the fuel filter great, but the fuel filter wasn't the problem.
Correct. And you wouldn't feel very good if the mechanic just told you that it's the way you're driving, right? So then, it's
which
like,
they did, and made me very angry.
Yeah, right. So again, it's like I've been driving for all these years. All of a sudden, why is this problem now? Why didn't I have the same problem with all these other cars?
Yeah, and then my brother ran the proper diagnostic tests
again
as a mechanical engineer, and
this is
the problem like that.
And this is where we need to give credit to people like Andrew Locke and Stuart McGill. Precise understanding and precise assessment, individualized assessment will lead us to the precise intervention, right? Then we play with the intervention, right? So the intervention is more even also individualized. And when I say individualized, hEDS come into play, hypermobility come into play, non-hypermobility come into play, male or female, that come into play, the body structure comes into play, your genetic makeup comes into play. All those things, they contribute to that assessment process, right? So I just wanted to clear that first before I,
so I wasn't just picking SIJ out of the air. I've had problems with SIJ for a long time. I know where the joint is.
Yeah.
I've been working with Shant for my SIJ for a long time, and
Yeah, so we started, like I said, in 2020. So we're very familiar with it. We understand the pattern. And every time the pattern has been the same, but our approach has been slightly different. And we have learned a lot of things along the way because it's a very under-researched, I would say, under-researched and underappreciated, it's come a long way. We have way more information available now. But what I know now, like I'll be first to admit, like what I know now in just the last 6 months, I didn't know last year.
Yeah.
And that has made me a better practitioner, and that should be the approach for every practitioner. Like we always constantly strive to get a little bit better. What we don't know, in another quote, from Andrew Locke, don't just look at what you know. Ask the question what we don't know.
Yeah. So something else I'll add on to that as well is something I've noticed, and I'll be interested to hear if you've noticed this as well with especially with the hEDS clients, is that often with I'm speaking a bit from what I've seen from other people because I'm hEDS. So what I've seen from my non-hEDS friends and athletes and people who I know is they'll have an injury, they'll have the pain or the what they notice of the injury, the pain or the problem show up.
Yep.
And then they get it assessed by someone really good like yourself or Andrew Locke when he was still with us. And they accurately assess their dysfunction, they fix the dysfunction. Then in 6 or 12 months' time, if the problem comes up again, it's often the same dysfunction or a similar dysfunction that caused it, that leads to it. What I find with hEDS, it's like that Mr. Potato Head toy, how you can change the head and let's say the head is what shows up, the pain or the problem or the issue.
Yeah.
The body can change out. The cause of it can change. It's this weird thing where it's like it appears like exactly the same, but the mechanism, it swings like a pendulum in all different directions.
Yeah.
So I might have what shows up as this SIJ dysfunction. The cause of that when we were working on my bodybuilding prep was one thing.
Yeah.
Years down the line, 5 years down the line, I've got similar problem in the same area, similar pain, or maybe just showing up, yes, it's my SIJ dysfunction, but now it's showing up as subluxation before it was something else.
Yeah.
But also the mechanism underneath it is quite different.
Correct.
And that seems to be something that I think leads to a lot of despair for us, because we might work with a physio and they really, really fix something, and then 2 years later the same problem comes up and we do the same rehab and it doesn't work as well.
Look, I can have 20 different answers for that question, right? So, life events can play a massive part in that. The physical demands, for some people who used to be very, big fan of powerlifting, and they were doing powerlifting, and all of a sudden they have taken up running, or, like high rocks or something like that, or CrossFit. Now the demand of the body has changed, and the human body is extremely adaptive. For terminology's sake, I'm just going to use the term hEDS. So if I'm referring to hEDS, I'm just going to put that under the hypermobile, I'm just going to put that under the umbrella as well. Okay.
So if you don't have a diagnosis,
when I'm referring to hEDS, I'm referring to everyone that has
the cluster.
Let's go with that. So you guys are specialists your bodies are specialists in adaptation, right? So my body is very good at adaptation if I have given it the right protocol. Your body is a very high level specialist. It adapts to a point, it goes past a threshold that it doesn't need to cross, right? And that's why I said, like, the mechanisms, like, we may do another podcast depending on that, but there's so many ways your body, the hEDS body, adapts. It's incredible. It's quite incredible to see. Like, we're actually having this discussion. People with hEDS, actually, they tend to build more muscles a lot faster.
Yeah, something else I've noticed is, and this is going off on so many tangents, we will get to the actual topic as well.
Yeah.
But something else I've noticed is, like, and this is what I usually teach. Usually if people want to get really, really good at something, we talk about specialized training versus varied training. Specialized is closer to the task that you're trying to perform at.
Yeah.
More, and then it's sort of on a spectrum, and then more varied training can be quite different, but usually we want to include variety because it creates a balanced body and all of that sort of thing.
Yeah.
Usually, in order to get very, very good at something, someone will need to do a lot of specialized training. What I find with the hEDS body and the hypermobile cluster is that what we need is stability.
Yeah.
And if you add stability, and we'll get exceptionally good at whatever task it is, even without a lot of specialized training. Like, I used the example when I first started working with Andrew, he got my glutes a bit stronger. My deadlift went from 170 to 190 in a month or two.
Right.
Usually, if you're getting that kind of a gain in deadlift, people would say, oh, you must be deadlifting 3 times a week, or doing deadlift specialist, or you've cut out squats and you're just focusing on deadlift.
Yeah.
I changed nothing except for a few glute activations that I added in. And I think that speaks to that adapting and highly adaptive.
Yeah. And interestingly, hEDS is one cohort that I actually had to use hip flexor training to counter that specialist over adaptation of the glutes, because they got so good at glute activation. It almost went the other way. So I had to bring in something else to counter that mechanism, right? So we almost had to create a bit of an equilibrium with the force production. So yeah, you're definitely right with that. Okay. So let's go back to my client, right? So with this particular client, and I would say, like, I see hypermobile and hEDS clients every week. Almost, I would say 30% of my clients would be, hEDS clients, right? With this particular person, we did all the right activation, and it managed pain really well, to a point I was able to get him back to deadlifting within like a couple of months. But the challenge was, once he started doing deadlift, he started getting pain the next day, but it just kept getting worse and worse and worse. And he was telling me by the end of the week, so if he deadlifted middle of the week, by the weekend, his pain is the worst, which is very different to the pattern that we see, right? So for example, if I deadlift on Tuesday, Wednesday it's a little bit sore, Thursday it's pretty sore, but then by the time the weekend rolls in, pain subsides. In his case, the weekend was the worst, right? So by the time Saturday, Sunday rolls in, he was excruciating amount of pain, to a point he could not even sleep.
Which is very similar to what I was experiencing. I was struggling to walk. I was actually, on the day that I think my SIJ subluxed, I went about like it was a normal day, because I was just in so much pain that's the pain that I'd been in for the previous couple of days.
Yeah.
And it was only towards the end of the day that I realized, wait, this is for subluxation. My pain's way worse today, and I can't stand up straight. This is what's been happening. But the amount of pain I was in was just like,
Yeah. So I generally stay away from using pain as a measure, but because I wanted to be very objective with his testing, I came up with the protocol, which is he is doing a flexion to extension movement, right? So meaning he's into flexion. So when he's in deadlifting, he's bending forward, which is flexion, and he's coming out of flexion into extension. Now, the underlying mechanism was he uses his low back erector muscles. Again, they all insert into that SIJ location, right? And I have verified and tested it's a true SIJ injury. And the mechanism was all the low back muscles were doing most of the work to get him out of flexion, right? So he was not really using his glutes. But not only that, as he is coming up, he was arching his back even more. So he's almost like arching his back as he's coming out. So that means his low back muscles are working so hard, and they're not big muscles, right? They're working so hard to get him into extension. By the time he's at the top, probably most of the work has been done by the low back extensor muscles. And in his case, that insertion point was really, really irritated, and it kept getting irritated, right? So the protocol, one way of approaching that type of problem is anti-extension. So if bending backward is extension, I will create a movement that opposes that. So McGill curl-up was a very good point to start. But in his case, McGill curl-up did not do anything with this deadlift, 3-4 days post-deadlift pain pattern. Well, that led me to believe, okay, so this must be a challenge with the demand of the task. Right, so McGill curl-up was really good for him to get him out of his original discomfort. Now that the demand of the task has changed, so we need to match that demand of the task with an opposing movement pattern.
Yeah, I remember Andrew Locke talking. This is where like my approach ended up being very similar to what Shant came up with for his client, because I just had, I went back into the gym to do deadlifts once my SIJ had sort of recovered, and I thought, okay, I'm going to have to, if it was my low back, my erector spinae muscles, my low back muscles that got so jacked up, because I have a similar thing.
Yeah.
They get overused. And I had actually done a lot of training to make sure that they weren't getting overused. I didn't find it, like when I did this slightly heavier front squat, it's easy to get discouraged and think, oh, I've done all of this work to try and make sure that my, arching my back doesn't happen so much and that I don't overuse my low back muscles so much. But actually what I was doing that day was a slightly higher percentage front squat. So I went into a different effort level. So usually I was working around the 7 to 8 out of 10 effort. This was actually a pretty hefty 9 out of 10 or 10 out of 10 effort. And what we know is that the muscles pattern slightly differently depending on whether you're close to your 1 rep max or not. So if your 1 rep max is 100 kilos, the muscle pattern and firing pattern that you use for 60 kilos is going to be slightly different from what you use for 90 or 100 kilos. And that's why I think it's important with Ehlers-Danlos to train yourself up to the level of effort or demand that's required of you in whatever it is that you want to be able to do pain-free. Because it's like practicing a fire drill when there's no fire versus when there is a fire. You're going to behave differently under a stressful situation. Fire. Exactly. Yeah, so you're going to behave differently under a stressful situation. So my body was like, oh, this is more difficult. I'm going to resort back to my old ways, which is fine. I can accept that, okay, I just need to, this was information. Yes, it was painful information, but it was information. But what I ended up doing was doing some really heavy ab training as well to counter, because I just remember Andrew Locke talking to me years ago when I was doing powerlifting. And it was similar. I'd gotten through my injury pattern, I'd repatterned the movement. And I remember him saying, you've learned how to do it. Now we just need to get those muscles strong. And it was just that maybe, yes, I've repatterned it so that my abs and my low back are more balanced when I'm doing easier work. But when I go to the heavier stuff, maybe those anti-extension, AKA abs, are just not quite up to the demands of the task.
Perfect observation, right? And I really like the phrase that you use, different level, right? So this is where, let's think about our rehab process as climbing up a ladder, right? So we want to get from point A, which is at the floor, and point B is high up where we want to reach. So let's call this bottom level rehab phase, and the next phase, the performance phase. So that's the level you're talking about, right? And that's the same thing happened with my patient, which is once we addressed the rehab phase and we introduced the performance phase, so I needed to come up with a performance anti-extension movement that matched the demand of the task, meaning his ability to counter that movement had to be a lot stronger at that performance, higher up on the ladder than what he was doing, right? So my approach with him was, okay, McGill curl-up gives you respite, but it's not helping you with your deadlift, right? And McGill curl-up is a brilliant exercise, right? It's, it has been tested. It has been, it's a very evidence-based approach. But when we reach the performance level, right, we need to make sure that we match the demand of the task. So I got him to do really heavy, let's call it almost anti-curl-up, right? So instead of doing just a regular curl-up, so he would hold a dumbbell and he would put the dumbbell lower down over his head. So the dumbbell is almost arching his back, which is the mechanism that he was using with his deadlift.
Almost like partway a dumbbell pullover.
Yeah, right? So you're almost going to that eccentric loading or the negative loading of the pullover. But as the dumbbell is getting further away from your body, the leverage is creating much larger pull variation within that extensor muscle group. So now your abs have to work equally harder to create that anti-extension flexion moment, think of it as an isometric hold, to be able to counter that. And he was really good at, McGill curl-up, but within just, I think we used only 10 kilos, and he was deadlifting, I think, close to 180 or 190 kilos, very similar to your numbers. With just 10 kilos, as he was lowering the weight, he started shaking. Like he was like, oh my God, my abs are about to cramp. So he didn't even have to hold it for like 1 or 2 seconds.
Which is such a common thing with hypermobility, to have such huge discrepancies in strength.
Yeah, that's what I said. You guys are specialists in adaptation. So you got so good at flexion to extension with that low back muscle, which is those muscles, they're not bad muscles in the human body. So those low back muscles has been doing a very good job. They're just not enough at that performance level to counter that. So once we introduced that counter movement, what happened was immediately his pain gone away. And that was the result. And again, you had a slightly different approach in terms of the timeline. But the reason I used his approach, so he did, let's say, deadlift on Tuesday, and I got him to do it on Saturday because Saturday he was in the most amount of pain. I wanted to, test my hypothesis. So once he did that, when the pain was worst, he had immediate relief and he had no issues throughout the whole weekend, right? So we built him up to, I think, close to almost like 15 kilos now, and he can hold for about 10 seconds and we haven't had any issues. The way I know, he hasn't had any issues means I haven't heard back from him and I see him in the gym, he's lifting an incredible amount of weight regularly, right? So bending backward, arching your back is the way he was creating pain. So I had to create a significant amount of more, counter force to be able to counter that. And it created that same, result or the outcome, which is we don't want to be in pain. Yeah. And generally, we don't want to. Sorry to interrupt. Generally, we don't want to use pain as a measure because pain is just a message. But in this case, I used pain. I was not trying to treat his pain, but I was just using pain as a metric to measure what I'm doing. Is it the right protocol or not?
Yeah, I see pain as very similar to scale weight. Yeah. Like it's not irrelevant, but it's not the only thing that matters.
Correct.
So it's like, it is important information if you suddenly have a loss of weight. Yeah. That is something we need to pay attention to, but it doesn't even come close to telling the full story.
Correct.
With mine, it was a very similar thing. I thought, what if I do some really heavy ab stuff? For me, I did it within the session. So I'm still interested to try out Shant's approach of doing it a couple of days later. For me, my thing is, I don't always know if I'm going to be up to doing training the couple of days later. I've been having a lot of migraines and things like that recently. Yeah. So I was like, I feel good in this session. I'm going to do it in this session. And something else I wanted to say is that for people listening, if you're experiencing this, you want to try it out, or you're working with a rehab specialist and you're wanting to try it out under their guidance. Shant suggested this exercise. I did different anti-extension exercises and the effect was still pretty good.
The approach was the same. The mechanism of the result, the result that we're trying to get was the same.
Yeah, and I think that's worth noting because anti-extension ab exercises. So anti-extension, Shant's already mentioned it, but arching your back is extension. So if you think of anything that prevents you from arching your back, that's the anti-extension stuff. So just regular sit-ups or plank, front plank, things like that are anti-extension ab exercises. A lot of them are triggering for Ehlers-Danlos, and
Correct.
you will go through a lot of different exercises before you can find the one that doesn't trigger your neck or doesn't trigger your head pressure or doesn't trigger your hips or whatever it is.
Yeah.
So if you can't do the one that Shant suggested, I actually did one that my neck doesn't love, but it was like, which is worse, SIJ sublux or my neck not loving it? I chose the neck not loving it. But it also tolerated it okay, which is just a weighted McGill curl up.
Yeah.
So I just held the weights up here and just performed a McGill curl up.
Correct.
An exercise Andrew Locke showed me many years ago, and Turkish get up was my two that I did. But both of them, the reason I chose those because I could load them. And I do my Turkish get ups heavy. I do 5 reps of quite heavy.
Yeah. And with the great thing about the Turkish get up, if you know how to do it correctly and you have an extensive, strength history, so your, motor dexterity is probably a lot better than, or should I say, it's a lot more experienced and trained than most. So I would not go to, if I do not know or have an understanding.
I've been doing it for years, like 10 years.
Yeah, and you've been working with Andrew for over a decade as well. So, but in your case, what you have done, you have kind of created a little bit same muscle groups, but you've kind of like unilateralized, if that's a word. You kind of like, focused a little bit more on one side, right? So when you're doing it from this direction, the left side is, getting a little bit more engagement. When you're doing it from the right side is getting a bit more engagement. And in your case, putting all those things together, that produced the desired outcome for us. Yeah,
I've been noticing as well recently that I'm responding really well to anti-extension work, to anti-rotation work, front and back. So that's another thing that I've added in. I haven't actually mentioned this in our discussions that we've had, but more intensive anti-extension stuff, because I think my thinking was the little, how our anti-rotation muscles through the back have a lot of proprioceptive function. I was sort of thinking, well, if I'm getting subluxation, maybe there's a proprioceptive deficit or some, the proprioceptors throughout muscles through our spine do a lot of work to sense where we are, and then they give that feedback to central command, which then tells our muscles how to correct. So I that was sort of my logic. Okay, I'm going to do some, so the camera just ran out of space on us. So the sentence that I'm saying might not flow on from the last one, but what I was saying was I've been doing some anti-rotation work, and that has I think it's made a difference as well, just to help, because what we've basically, Shant can probably explain this a bit better than me, but they dissected some of the small muscles around close to the spine, and they found that they had a high percentage of what we call muscle spindles, which are a part of our proprioceptive function. So proprioception is the joint's awareness of where it is in space, the body's awareness of where it is in space. It's not necessarily conscious, but it does inform what we do. So if the body's sensing where we are in space, it sends that message back to our central command, and then our central command can activate certain muscles to correct and things like that.
Correct.
And with Ehlers-Danlos and hypermobility, we tend to have impaired proprioception, although it is something we can train. So that
or it can be compromised as well. So the quality of information, the amount of information is not also getting through. So it's a little bit inhibited, so we kind of excite them a little bit more. So the headquarters is getting a lot more information. So with more information, it can make better decisions and better instructions. Yeah.
So that was sort of my reasoning, is I thought, okay, I'm going to do some anti-rotation work, but then we've got this other thing that I've talked about with Ehlers-Danlos. Actually, in my last podcast, I talked about it, the window of tolerance, where if you go, it's like Goldilocks and the Three Bears. Too soft, we don't want the bed to be too soft. We don't want it to be too hard or the porridge to be too cold or too hot. We want it just right. So I found things like bird dog, which does work the anti-rotation and the proprioceptive function through the back. I found that was a bit too light for me. So I've been doing things like single arm unsupported rows or weighted bird dog rows and things like that. So that's, I can't remember what I was saying before this, but that's something else that I've added in. So that's why I did the Turkish get up, because I thought as well, okay, it's a bit of it's a bit different than the proprioceptive stuff through the back, but just in general, anti-rotation stuff has also been very helpful for me.
Absolutely, right? So we want to think about the 3 planes of motion. We have frontal, which is side to side, sagittal, which is front to back, back to front, and then we have rotation or transverse, which is our body's ability to rotate. And we want to make sure that all systems are addressed, and obviously based on individual assessment, so the right approach for the right person. But we need to ensure that all the systems are assessed properly, and we have some level of intervention to address those three systems, which is the three different directions of movements, right? So yes, the deadlift is a sagittal plane, which is in this direction, so bending forward and bending
backward. Or the front
backward.
squat, which was what set me off.
Yeah, and it's a sagittal plane movement. However, even within that sagittal plane movement, we have frontal plane stabilizers coming in as well. So we see a lot in one side of side plank is a lot weaker than the other side. And once we address that, that fixes the problem. The same way, rotational, challenges can be a challenge as well. So we addressed a little bit before about the SIJ dysfunction. Articulation, movement within a joint, like your ball and hip socket joint. If there's a dysfunction there, that will contribute to your SIJ dysfunction. And what happens is, let's say there's a dysfunction, right? I'm not going to get into so many different types of things that contribute to that dysfunction.
When we say dysfunction, we're talking about some kind of, when we're moving and interacting with the world, something's not happening quite how it should, and as a result, problems are arising.
Yeah, for that particular person, the movement should be done this way, and the message that is coming from the nervous system to those group of muscles to create that right sequence is not happening correctly. So that is impairing our ability. So think about your wheel alignment. If it's a little bit off, you can change the oil, you can put the best brakes in the world, but if your alignment is a little bit off, the car's going to keep moving around.
And over time, the tires will wear unevenly.
It's going to affect a whole bunch of other things. It's the same approach. So even within that deadlift pattern, there are some rotational things happening within the hips. So we need to address that. If we're going to create rotation through one joint, so the other areas, say for example, our spinal stabilizer muscles, need to be able to create anti-rotation movement. Again, if there's a bit of a deficit, and the deficit is above the threshold of the task, what's going to happen is you are going to have discomfort. So in your case, by addressing the right loading at that performance level, rotation and anti-rotation work has helped immensely. And I see that a lot. For somebody at the acute stage of low back pain, it doesn't have to be hEDS. Bird dog is a brilliant exercise. But for some, bird dog does not really do much, but when I get them to do heavy renegade row, which is a much progressive version of that anti-rotation movement, immediately it produces the result. Same thing with proprioception walks. You might have seen those videos, where we do holding like a broomstick and having a weight only hanging on one side, walking back and forward, and then change sides. That also challenges that anti-rotation, component, but that's also proprioceptively challenged as well.
Yeah, and I think as well with the bird dog, like there have been times where it's not just like this person it might work for and that person it might not. I remember when I was really strong, bird dog was so hard for me at one point, and then it became really easy, and then I needed something different. So it can fluctuate even within a person.
And again, it's the ability of the clinician or the coaches to be able to tune to the task. This is the task, this is the demand, and this is how the body's responding to it. And we identify through individual assessment, where do we have the deficit? And we kind of keep plugging the hole.
Yeah. So we've talked about, firstly, the pattern that both myself and Shant's client, and also the person who I was talking to from my Bendy and Strong course, had of we do this thing, and then the pain dial keeps turning up and doesn't go down, and then we end up with something probably subluxed. We talked about how we had these two very similar but slightly different approaches, basically working heavy in the opposite direction, whatever was pulling too much, let's say, we worked heavily in the opposite direction. The difference is Shant with his client was doing it a couple of days after doing the initial exercise, whereas for me, I did it on the same day. And we kind of have touched on how it's a bit different. Like we talk about how great activations are, which is activating the muscle beforehand, but they're usually a lot lower load. And this is what we're talking about here is more about, it's not about neural priming and activating, it's more about getting strong and building the capacity for that muscle to function properly within the demanding task.
Yeah.
So I've got two more questions about it, and then one comment to make on potential mast cell involvement.
Before I actually get to the next two questions, you use the word strength. So one thing we want to be very clear about, strength is a skill.
Yeah.
And then the skill starts with a videotape in our brain. So that's why we do not want to dissociate strength from motor learning. Something as simple as, lock clamp can build the foundation, and building on that can give us the skill, right? So a person who's doing sumo deadlift is very strong in sumo deadlift, whereas a person that is doing sprinting, they're very good at sprinting. So I have a strong sprinter, which looks completely different, and the demand of the task is completely different to the person who's doing a heavy sumo deadlift versus a conventional deadlift, right? So again, going back to the principle of tuning to the task.
Yeah, I would add something else onto that prompted me to think of as well, and that is that strength is also relative. So what your client did might not be the right thing for someone else. And if you're listening to this and you're at a much more, I've been training since I was 13, I'm quite highly trained. If you're newer to lifting, you might need to do something. You could, maybe bird dog would be the right exercise for you, or a basic McGill, unloaded McGill curl up might be the right one that's the right intensity for you.
And for some, just learning how to deadlift correctly. So my client, he's a very strong person, and I should also clarify, he has hEDS, by the way. So he's a very experienced lifter. But because of the weaknesses that he had, or the dysfunction he had, he kind of his body adapted to do the deadlift slightly differently.
Yeah, and I think that's sort of, I guess, the disclaimer for all of this is we're talking about two people in this instance who are good at deadlifting, who've got the technique down pat. And it's almost like nothing you can quite obviously see to change while deadlifting or while squatting, but it's the aftermath that is where we're seeing that there was clearly a dysfunction going on.
Correct.
So the next thing is that for both of us, what we've described is this overcompensation with our extensor muscles of the back, leading to SIJ dysfunction. Why have we seen this in two people now, in him and in me, that we both complained about excessive arching of the back. We both noticed that that's a dysfunction for both of us. We both complained about excessive DOMs in the low back. Why does that lead to SIJ dysfunction? Do other things lead to SIJ dysfunction, or is this sort of one of the main ones? Yeah.
So this is probably the main ones that we see, and the other common one that I see is running or walking. So those are the two most common things that I see. Squatting, I have found to be not a very strong aggravator of SIJ dysfunction. It creates aggravation, but not as much as deadlift when it comes to bilateral, meaning double-legged compound movements. Whereas the same thing with walking or running, same pattern, but different movement pattern and different force production. So those are the two things that I see a lot in my practice when it comes to SIJ dysfunction. But if you look at the movement, the three planes of movements that we discussed, it generally happens when they perform the sagittal plane dominant movement. So when you're doing deadlift, flexion extension, or running, you're extending through one side and countering that movement flexion through the other side. So when your one leg is driving you forward, the other leg is bending forward as well, right? Or the opposite direction. It's very common because generally most of the things that we can do that happens in that frontal plane, which is side to side, tend to be more to do with stability, right? The things that we do forward, think about most of the sports, whether it's running or basketball or powerlifting or strongman, the primary direction is that sagittal plane. And most people who go to gym will be doing those movements, whether it's kettlebell swings or deadlift or front squats.
Or bicep curls, or back extension.
All those things. So the prevalence of those movements are high. So we're going to see that. In saying that, I see issues within that frontal plane as well, where people tend to kind of bend one way. So I have to get them back into neutral before I can access the sagittal plane. But it's more common in that direction. And the other thing that we want to remember, what we discussed about the anatomy of the human body, which is most of the extensor muscles attached to that SIJ location. So the most amount of force is being produced in that location. And if there's a dysfunction, whether it's strength deficit and or articulation, meaning the right movement pattern, then it will contribute to that problem, right? So think about a Formula One car. They have a very specific set of problem versus think about a four-wheel drive in the undulated ground in the mountains. They have a very specific set of problems, right? So that means the playground that we play in is the one that's going to determine the type of problem that we're going to have. So I cannot win a Formula One race with a four-wheel drive, and a Formula One car would not even climb up a mountain.
Yeah, I think the way that I sort of pictured it with my back was it was almost like, because I know that the erector spinae muscles attach on around that area. It almost
not just that, your glutes, all that, they're all attached in that area.
Yeah, but with the erectors getting so angry and inflamed, it almost felt like that potentially could have created too much force in one direction on a joint that was already quite unstable because of my hEDS.
Yeah, absolutely. And that's another thing that we want to touch on, which is movement generally tend to be the underlying trigger. But the intensity is modified by so many or impacted by so many things. It's not just one thing that is contributing to it. One big discussion we've been having recently for the last few months has been MCAS, the regulation or stabilization of mast cell.
Or not even, I feel like MCAS is it's the correct word to use, but for so many of us, we might fall MCAS is a hard diagnosis to get because the blood tests involved are very finicky and not many doctors know, there's debates around the diagnosis criteria as well, and not many doctors know what to look for, et cetera, et cetera. So even just mast cell issues full stop, because that's what I suspected happened with mine. What I've noticed is when my mast cells were inflamed, whether I'm stressed, whether it's around menstrual cycle, whether it's, I've noticed a difference on or off a mast cell stabilizing medication. And I've mentioned this to other people with the same sort of cluster, and they say, yes, that's what I find too, is usually the things that I can usually get away with that don't cause a problem, all of a sudden it causes a big problem when my mast cells are inflamed. So I might do some upper trap work. I never really do shrugs or anything like that because my neck doesn't like it, but something that involves my upper trap, like deadlifts or overhead shoulder press. And usually I can get away with it. Sometimes if my upper traps are a bit angry, I might just think, my neck's a bit stiff the next day. But when my mast cells are inflamed, it's like an overreaction. It's like a toddler having a tantrum, and it just overreacts, and I end up with a migraine.
Yeah.
Or with this issue with my low back, usually, my low back gets my erector spinae get a bit sore after a front squat or a deadlift or whatever. And usually, sometimes I might think, I can only feel it in my erectors. That's a bit annoying because I was supposed to feel it somewhere else and I know to correct it.
Yeah.
But because my mast cells were inflamed around this time, I suspect that that's sort of what it caused it to.
It's like a catalyst.
It is a catalyst because a catalyst in a chemical reaction lowers the ionization energy required for the chemical reaction to occur.
Yep.
So this is lowering the amount, it's lowering the threshold down for something not so nice to happen.
Yeah.
So that's sort of, I think we've mentioned this a couple of times, that hEDS or the cluster is a very multi-systemic approach required. And more and more, I've been reading this book, Never Bet Against Occam. I've been telling everyone to read it. I've mentioned it in all my podcasts recently. The more I learn about that, the more I realize the role for mast cell stabilization and stress management. I know that's a bit of a annoying thing. It's often not stress. People think of stress management as getting rid of all stress from your life. No, it's learning how to deal with it and handle it better and not storing it in your body. And so many parts of that is so important in this, because since being on mast cell stabilizing medication and working through this with my doctor, my body's so much less reactive.
Right.
And I can do things and make it it's like I've got more suspension on my car, or I've got more margin for error. And I'm not constantly...
It creates a buffering zone.
Yeah, it's a buffer zone. And I think that's a big part of hEDS rehab or this cluster rehab that is either not addressed or it's addressed the wrong way, as in people say, it's just a mast cell inflamed thing. But what I've found is every time I have these issues, the biomechanical, we've described this biomechanical basis for this issue happening, that there was actually a observable biomechanical dysfunction, but it just becomes either heightened or more sensitive or more reactive.
The bodies respond to it.
With the mast cell issues. It's not that the mast cell issues, it's not, people point to psychosomatic. It's not psychosomatic. It's the brain has, it's not that the psycho stuff is creating the pain. There's a missing link there. It's the mental state, because this was made a lot worse by stress, that then inflamed my body, and the inflammation heightened an already existing pathway.
Yeah.
So I think that's how it's mismanaged. And I love that people are learning more about MCAS and mast cell stuff, but I'm really nervous that there's going to be a lot of rehab clinicians who will start to say, oh, it's a mast cell thing, and not actually. A lot of the time, psychosomatic stuff, I think, is diagnosed as psychosomatic because the clinician doesn't have the skills to understand and diagnose things.
If we consider hEDS as a sport, then it's a very well-oiled, it has to be a very well-oiled, machined team sport. Sometimes, we both have experienced this. Like one person, they think it's just this one thing that contributed to it. And it maybe started with one thing, but there are so many contributing factors it's kind of like a spider web. There's so many things impacting from so many different, pathways. It's not just all biomechanical. Yes, biomechanical tend to be a big part of it. Then the physiological response, the neurological response, they all play a significant part. And I really like the idea of we like to stay in our lane, but I know what my role is within that team sport. My role is to understand the biomechanical breakdowns, but every time we discuss, you do your other things with other specialists to manage other part. Like I'm not a qualified practitioner to deal with any of it, right? So yes, it can be that one thing that may have triggered something, but we also want to have a look at from all these different vantage point, what else is contributing to it? Something that he mentioned, menstrual cycle. Even someone who doesn't have hEDS, they can get SIJ dysfunction, which gets more exacerbated during the menstrual cycle.
Well, also, if we're talking about mast cell issues, there are mast cell experts who estimate it's 1 in 5 people who have MCAS. So think about people who may not have diagnosed hEDS, who may have this hyper-responsive body that changes around, for me, I get more migraines around the weather changing. I get fatigue around the weather. My mum and I, our fatigue is always lined up. We always feel a bit tired around the same time because we live in the same city.
And again, this is where every clinician, we need to put our ego aside and we need to understand this is my role, but there are other areas. I do not need to fix everything, but I need to recognize what other things that may contribute to it. And a lot of it is based on for example, when it comes to MCAS, the most amount of information that I have gotten was from you and your work and all the things that you have researched into, and also a lot of the feedback that I have gotten from my patients, what they have done with their specialists to manage not just MCAS, POTS, and a whole bunch of other comorbidities that come with it. And I have learned I need to do this, and this is the problem that I can fix. Again, we're going to use the analogy of a car. A panel beater is really good at fixing the body of the car. And a good engine mechanic is really good at fixing the engine. So if you have two different problems that is contributing to the car problem, then we need to make sure that the panel beater and the engine mechanic working together to make sure to produce the desired outcome. And this is, I think, one more thing, which is, I can feel like a lot of people, they get frustrated because they think they're doing the right thing, and they may be doing the right thing, but there may be other right thing or things they're not doing.
I think that one speaks very strongly to me. I talk about it a lot on here. My Ehlers-Danlos'er got a lot worse around my dad dying. Grief is a big trigger. And then it got a lot better. I was on a mast cell stabilizing medication. Life was feeling a lot more cruisy. Things were smooth sailing. Then I had personal stress come up. And even though I was on the mast cell stabilizing medication, it showed it I got inflamed again. So if I'd been going through that stress whilst I was put on the mast cell stabilizing medication, it may have come up as a false negative. But what it actually was that it was having an effect, but there was another piece to the puzzle.
Yeah.
Which it makes this whole thing very hard to manage, but I think that's why community and conversations are so important.
Yeah, and also sharing information. Like I said, I learned just as much from my own practice and my own research and my education and information provided by my patients, right? So they give me so much information that gives me a completely different vantage point. Like I didn't know much about MCAS until I started reading about the book, that you mentioned before.
I didn't know much about it, and I've got the freaking thing. Like I didn't know much about it, and I've been living with it for my whole life.
Yeah.
Yeah.
And again, previously, and I've made the mistake of believing, things like BPC and prolotherapy, and I didn't know enough about their efficacy. But then now we have so much research available, especially a gentleman called Keith Barr. Highly recommend looking into his work. It's not necessarily the chemical compound that is helping, is the pithing of the needle into that tissue, creating micro trauma or micro injuries that almost forcing the body to adapt and create a reparative process or regenerative process. So and this is where, whether you inject BPC 157 or you inject just saline, bacteriostatic water, they both produce the same result as long as the injection was done in the same frequency in the same site of injury.
Yeah, and that's where things like acupuncture and stuff probably have such a positive effect as well, because that's
correct.
In the hEDS community, I've heard amazing results from acupuncture, but then sometimes I hear people say, it didn't really do much for me. Well, maybe for you that wasn't the pathway that needed fixing. Yeah.
Right. Again, it's
like my car, we fixed the fuel filter. It wasn't the fuel filter, it was the oxygen sensor or something else.
Yeah.
But for another car that's fuel filter was the issue with acceleration, it would have been the perfect fit.
Yeah, and if it's that type of connective tissue disorder that requires that some level of stimulus to create that reparative process, and if some level of pithing is the mechanism, then yes, we are going to be able to produce incredible amount of result. So a good practitioner, not just good practitioner, I think, hEDS, you guys are incredibly intelligent people. Like some of you know actually more than most clinicians do.
Yeah.
And because of your life experiences and all the trials and errors that you have gone through. Yeah.
The autism and the ADHD.
Neurodivergence, it's a brilliant gift. And the it's not that something is fixing it, and we don't want to stop there. We need to understand what is the mechanism that is.
Why did this set our path straight?
Correct. What is the mechanism, underlying mechanism that is fixing it? Once we understand that, the process, then we know this is the specific set of problem and I know the right tools to bring in. So acupuncture for the right person can be a brilliant, intervention along with other right tools. Something, I think we discussed a few months ago, changing diet and bringing systemic inflammation down. And every single patient with hEDS that I have spoken to that have taken on that advice went to a specialist dietitian who's familiar with that approach. They all have said, I still have my flare-ups, but the intensity has gone down significantly. It's almost like I started feeling a lot better. And I'm not promoting any specific diet. These are all individual diet for those individual people that has resulted in bringing down the systemic inflammation, and they have measured it through blood test results and all that inflammatory markers. They have seen that.
I think there's a few I would call them blunt instruments. They're not very precise, but they just kind of fix a lot of things. Exercise, enough sleep, eating the right way for your body.
Absolutely.
That was sort of what, I was put on low-dose naltrexone, which is the mast cell stabilizer that I take, by a pain specialist, and then I talked to my GP, and he said it's a very blunt tool. It kind of fixes a lot of things, but we don't necessarily know the precise way that it works. And I would put exercise and diet and sleep and recovery and having passions and community and things like that underneath that category. And actually some research by one of my friends, Jade, she's talked about this research. I don't know if it's out or not yet, but they found that it was something, I'm maybe misquoting this and I should get her to say it, but it was something along the lines of they looked at all of the different factors that contribute to someone's feeling of success or contentment from their chronic illness experience.
Yeah.
Community was the number one factor.
Oh.
even just like if you go to a bad doctor and you want to mouth off about them afterwards, you've got community to back you and say, no, you were right in that. You know, stand your ground. Or if you're feeling like you can't manage things properly, someone can step in and help you. Or just having someone, you know, loneliness is such a predictor of health factors these days, and so things like that are quite blunt force things, but they can have a huge impact.
Yeah, and again, it's not exclusive to hEDS, but in many cases, let's say we have and some level of dysfunction which resulted in overcompensation type of injury, which resulted in very high level of inflammation in a specific joint. Let's go with the SIJ, right? There's a significant amount of inflammation to a point I can't even get them to do the most basic movement. So if they just take some anti-inflammatories, not that I'm prescribing it, I'm just using as a general concept, taking anti-inflammatories for a couple of days where they have been able to control that inflammatory induced pain, they are able to start doing the activation or the corrective exercises, then all of a sudden they can taper off the anti-inflammatory, but that has given them the window of opportunity to start the process. And it gives us, you know, let us step into that process. And the thing about community, and this is something I've learned, you know, like with the hEDS community for the last 5 years since I started working with you, is it's a very proactive and very interactive, and it's an activist community. They are not dormant. And this is something I recommend to...
We're rebels.
Well, it has very important implication on a clinician's practice. If you're a very good clinician and you put in the work and you understand your role and you produce the result, everyone's going to know about it. If you don't do that, everyone's going to know about it. If you're a clinician who consistently have, you know, not being able to, I'm not going to name names, but I know a lot of my hEDS, like they have seen this particular physio because, or osteo, whatever their profession might be, they have seen that person because they claim to be specialists in, but it feels good for a couple of days or a couple of months, and then all of a sudden, and then there's nothing after that. And it's not just one person, like we all have our outliers. Like I cannot put hand on heart, so like I have been able to fix absolutely every single person. But if you start finding that pattern, that a lot of people are saying the same thing about you, good or bad, this community will let everyone know.
And we've also got like lack of inhibition and willingness to speak our minds and all of, I as a clinician also, you have to kind of accept that, and you'll get blunt feedback from this community, and you just take your ego away and take it, because it's going to be some of the highest, like it's like gold, it's worth its weight in gold.
I see them as opportunities, because if something didn't work, then obviously I did not find the right solution. So in many cases, you know, and you remember the last time, not the last time, quite a few months ago, you had the hip or the adductor pain, and I couldn't fix it the first session. And I went through the session over and over in my head, and I messaged you like, okay, I'm losing sleep because I know I missed something. Can we just book in? And I do that with my clients. Like sometimes I'll tell them like, you don't have to pay me for that session.
I think the reason that we had that conversation is I was in a really bad mood one day, and I just was being very polite up until that point, but then decided not to be polite. And I was like, it's not working. This isn't doing anything. And then that's when things actually started working.
And I get that sometimes. I get that with my patients sometimes. And sometimes that leads me, even within that anger, they will give me a piece of information that I might have missed in my assessment. But in some cases, you know, I've actually done that, and my patients, some of my patients can vouch for that, is I will tell them, can you just come see me? You don't have to pay me for it, but I know I have missed something. I know that. Can you please come see me? I need to address this because it's a learning opportunity for me. Because if I know this new skill now, that's going to help my career and my education and my skill set as well in future. So again, and this is a little bit more me as a clinician speaking out to other clinicians. Don't get disheartened by harsh criticism. See them as opportunities to learn, because this is such a new field. Well, it's not a new field in terms of existence, but it's a new field in terms of how much we know about it and how much information we're getting. And it's a great opportunity. Like I said, I know more now today than I knew last year, and I'm going to say the same thing next year, that I know in 2026 more than I knew in 2025.
Yeah, for sure. I just want to, bring it back to the conversation we were having about the SIJ stuff.
Yep.
Because there's two more things that I wanted to say. One of them, it just prompted me from that discussion we were having about the inflammation stuff. Another thing, so I've been doing the heavy ab work. I've also been doing more anti-rotation proprioceptive work. But another thing that I've been doing is being a lot more adaptable with my training, as in if I'm having a bad day.
Very good point.
Mentally, if I'm having a bad day, I won't do deadlifts that day.
Yeah.
My grandma died recently and I pulled back a little bit because of that. Another thing I've been doing is still progressing, but I've been keeping my effort level low, slightly lower, because I knew that when I went to that 9 or 9.5 out of 10 effort, that's when things repatterned and went not quite right. So I've been keeping it, I'm progressing still, but I'm keeping it to about a 7 or an 8 out of 10 effort. And avoiding that top end effort range. But interestingly, what you find is when you do that and you still progress each week, this week I deadlifted, I think it was 130 or 140 or something. And if I'd done that 3 weeks ago, that would have been the 9 out of 10 effort, but now it feels like a lot less. So it's one of those things as well.
Yeah, and absolutely. This is the undulated, and it kind of leads us into the realm of, and not exclusive to, but in the realm of Randall effect, where one thing feels really good for a while and then it doesn't feel good anymore. So my first approach was to start with the activation. Right. So the first thing was, let's come up with a protocol where I'm trying to engage this movement, but I'm also trying to train the opposing movement as well. Then my next approach was, let's come up with 2 sets of activations. So you do them on alternating days. This day it focuses a little bit more on this direction, and the other day it focuses a little bit more on that opposite direction, or the force demand or the movement demand is slightly different. The outcome is the same. Again, on the ladder, it produced result to a point. Then our next phase, and we were discussing this, and I tried that with one of my clients with hEDS, and we did that. I think you did that with yourself as well. Is the undulated training, right? So you guys are specialists in adaptation. So if you keep just hammering in one thing, you're gonna over adapt to it to a point. It's gonna start hurting the other the thing that gave you respite. So 1 week we're doing sumo deadlift. The next week, we're doing trap bar deadlift. The next week, we're doing Zercher squat.
So that's undulating. Undulating, it doesn't have to be exactly that, but it's sort of...
It's an example.
Not doing the same thing.
Please don't do that, just start doing this.
Yeah, but undulating as a concept, not doing the same thing week after week, or a linear progression, but sort of going up and down, whether it's with rep ranges or weight or exercises. It's rotating is probably another word for it.
Correct. And undulated, it can be, somebody who's as experienced as you. I didn't tell you to do those things. You have enough lifting experience and knowledge, and you're an exercise scientist yourself and spent a lot of time with someone like Andrew Locke. So you found what worked for you on that day. It may not be the case for everyone, but for coaches, what you can do, if you have somebody with hEDS and hypermobility, you can play with that undulation. It doesn't always have to be that every week it has to be different. It can be you do small blocks, like 2 to 3 week blocks, and then you change the compound movement slightly, and then you run another 2 to 3 blocks and you run the compound movement. Again, we're playing with it, right? See what works. But undulation of that training program, it was one of those other light bulb moment. It was a game changer for us.
So one other thing that I wanted to go over, just to clarify, and this is something that I get, I think this feeds into another concept that I've talked about. I can't remember if we've talked about it before or not, but it's this idea of when we have a tight and overworked muscle, the response is, from a everyday perspective, a lot of people will approach it by stretching it or massaging it or dry needling it. And we say, no, we want to figure out why it's tight and overworked and work the opposing muscle. And we're kind of talking about that here, slightly different though, because we're saying, no, we don't want to strengthen our back less. We want to strengthen other things more. But why did we choose to pair it with the antagonist? So with muscles, antagonist is the opposite muscle. So if I'm doing this with my arm, that's my biceps among other muscles that are doing that. The antagonist muscle is the opposite muscle that does the opposite things to the triceps. So why did we choose if our erector spinae, our low back muscles, the muscles that run down the length of the back, on a really jacked person, you'll see them sticking out so you can't see the spine, basically. Those muscles were what were overworked in me and your client.
Yep.
Why did we choose the abs or the anti-extension?
Okay.
How did that function? Why did that work?
Let's start with an analogy first. Right, so think about a telephone pole. So I'm going to borrow this from Professor McGill. So think about you have a telephone pole, right? Let's pretend this is a telephone pole. If it's just sitting on here, if I let go, it's going to fall over, right? But if I attach ropes from multiple directions and they're all pulling equally.
Like a tent with a pole in the middle.
Yeah, so tent with a pole and they're all pulling equally in multiple directions, what's going to happen is this is going to stay upright. If one of the rope breaks or becomes lax, the other one will start to pulling it in that direction and it's going to fall over or topple over. So human body, especially let's go with the spine since we're talking about SIJ and the lower limbs. We have forces producing in one direction. That means there are going to be counter forces in the other direction. And stability is something finding the equilibrium within those forces, right? So if I'm not stable, if I want to stand on one leg, I have to have all the muscles in all directions to be able to produce force to keep myself upright. If something is really strong in one direction, what I notice, this starts to fall over in that direction because it's pulling so hard in that direction, and then the opposing muscle groups are not doing it, or the antagonist muscles are not doing a very good job to counter that force. It is going to create that dysfunction, or it's a form of dysfunction.
So it doesn't always have to be the antagonist muscle that's dysfunctional that causes these issues.
Yeah, so that's what we're talking about. Like the sagittal plane, the frontal plane can play a very important role in creating, so this is why precise understanding and assessment comes in handy.
But usually, because whenever I talk about this concept, people always say to me, but how do I know which muscle is the underworked one? Often the antagonist is one of the first places we look. Yeah.
Correct. So let's build on that. So now that we have understanding of that analogy of the telephone pole with all the guide wire system, let's just say that there's only one way the pole can fall over, right? Either in this direction or this direction.
Left
so
or right.
It's just one direction, right? Whether it's right or left, one direction. So let's understand a couple of concepts. The first one, reciprocal inhibition. So you just demonstrated bicep curl. So reciprocal inhibition means if I want to facilitate my bicep muscles to create this movement, that my triceps will have to relax to allow that to happen.
It's a neurological principle.
Correct.
It's like one of the rules of the body.
It's a theory invented by Lord Sherrington, won a Nobel Prize for it, I believe. And he got his lordship because of his contribution to neurology, or in the field of neurology. So it's not a concept or a theory or an idea, it's a theory. It's been valid, and it's been validated, and it's been proven to be right. So that's number one. The next one is the realm that we tend to play, or I tend to play with, is the arthrogenic neuromuscular inhibition. Arthro means bone, genic, so it has to do with the joint, so the bones. Neuromuscular, neuro means part of the neurology, muscular is muscle. Inhibition means something is being inhibited. So one of the things that we see, if something is being overworked, we tend to flex everything or tighten everything in that direction to protect the joint. It's a neuromuscular phenomenon. So whatever happens when we hurt our elbow, we immediately go into a natural splint, right? So if the low back muscles or my agonists, the one that are in agony doing all the movement, they are doing most of the work. They are gonna flex or tighten and shorten and create that pattern. So what I need to do
and pull on the bones,
and that's why like you see with cricketers, they have a lot of pars injuries. You'll see a lot of gymnasts, they have spondylosis, stasis and all that. So again, excessive movement or compensation in one direction can create that arthrogenic neuromuscular inhibition. For an example, if my glutes are weak, my hip flexors will tighten up and create pain at the front of the hip, or what we call tight hips. Okay, now we understand two phenomenals.
So the arthrogenic neuromuscular inhibition, that refers to the muscle being inhibited or the joint being inhibited?
So the muscle being inhibited.
So the muscle, like for example...
Well, okay, let me correct that. So it's referring to the play of all the systems. So that's why it's arthrogenic. So within the joint, the role our neurology is playing with the muscles to inhibit. So if I flex something, it's almost like inhibiting that joint to stop it from movement, right? So if I tighten up my hip flexors, there's less movement within the hips. It's a phenomenon of our nervous system to protect the body.
Okay, so arthrogenic neuromuscular inhibition refers to the fact that certain muscles will tighten up when they sense that there's something wrong in that area.
Correct.
To inhibit that whole joint or structure.
Correct. And you probably hear from a lot of the biomechanical studies by Professor McGill of neural inhibition, right? Same principle. Okay, so if we understand something is doing a really good job, such as your low back extensor muscles, the opposing muscle groups at the front, that means they're not doing a very good job. So we need to create a stimulus, an external stimulus. For an example, in your case, your variation of the curl up. In my case, adding that pull over variation of the curl up. So now I have used a tool to bring the other players back into play, so we can bring things back, bring that guide wire system back to the center.
Yeah, okay, so in this model, overlaying the arthrogenic neuromuscular inhibition stuff into it, we would be saying that the erector spinae, the low back muscles, are becoming overly excited in order to inhibit the area or sort of protect that region.
It's the protective mechanism. That's why we like to use the term like a natural splint of the body.
I think the inhibition word can be confusing for some people because usually we use that to refer to muscles being inhibited, but in this case it's not. It's inhibiting the area, and then as a result we're basically doing the heavy ab work to say, okay, don't stress muscles. You don't need to stress out so much. It's okay.
Yeah,
it's fine. We've got control of the area, because that's a weird thing with Ehlers-Danlos, I think, because we can tend to have instability in our joints. Not necessarily that we will, but we have a more tendency for it, and we have to fight harder against it. So we get these chronically tight muscles that often it's as a way of sort of protecting the joint, but it ends up hurting us.
Correct.
Being annoying more than anything.
Back to the point of hEDS being a very, very good specialist in over-adapting to whatever the dysfunction that we're dealing with. So the dysfunction, hEDS, non-hEDS, exactly the same dysfunction. More often than not, the hEDS will over-adapt as a counter mechanism compared to a non-hEDS person, and that's why with hEDS,
hypermobile,
or hypermobile. So, that's why I see hEDS clients a little bit more often or more frequently, whereas like my non-hEDS, most of the times I see them once, maybe twice, and then I never see them again. The only time they come back to see me is they stop doing their activations and just gone back to the same mechanism. Well, like with hEDS, because now I have to constantly play with their adaptation process. They have really over-adapted, and this is a skill I've been learning and getting good at. And Rendell effect played a massive role in that. But back to the point of why the antagonist. If this is overworking, I'm not going to punish that. I'm not going to massage the crap out of it. I'm not going to stretch it. What I need to know, if this is doing a really good job, who else is not doing the best job?
And the first place we look at is the antagonist. Yeah.
So here's an interesting concept. As I deal with a lot of tendinopathy, interestingly, that's how I got a lot of my information, or my starting information, in the field of hypermobility or connective tissue disorder, which is a lot of my tricep tendinopathy, I need to do extension holds, but then I will give them lighter bicep curls. Right? So
just to relieve, yes, we're working that area and we're strengthening the tendon, but we also need to give some relief overall to the joint.
Correct, right? Because it's getting overly, used because there's a dysfunction. Yes, I'm correcting that dysfunction, but I also need to make sure what is also not working more often than not I see is that bicep muscles, more the medial part of the bicep muscles, they have really tight, what's the muscle called? Brachioradialis. That's the one, right? So I will give them some light movement, like very controlled light movement, to not just address the ANI, but also restore the function of that joint as well.
Yeah, I think the thing I find it hard to confusing to convey is, and I've just absorbed this over the years of working with you and Andrew and other really good rehab and strength coaches, is that sometimes it's the antagonist that's the weak one, that's the underperforming one. Mm-hmm. Sometimes it's the synergist. Sometimes mm-hmm. it's one of the helper muscles that is like, you know, we might find that the TFL, the hip flexor, which is also a hip abductor, that it gets overworked because the glute med and glute max and glute complex aren't working properly. So sometimes it's the synergist, which is a muscle that does a similar movement.
Or it can be a combination of both.
Or sometimes it's a combination. But I think in this instance, it was pretty, like the antagonist seemed like such an obvious choice to me.
Yeah.
Because I've got that excessive extension and my erector spinae just pulled me into that excessive extension, and it felt like that was really the mechanism by which over time, you know, I did the front squat on this day, and then 5 days later, over time, it just built up and built up and built up until it just pulled.
Yep.
So that was why, for me, it felt very obvious that it was probably, let's start looking at the antagonist.
Yeah.
Start there. But then again, I did do also the anti-rotation work. But I think that if I had to choose one thing, if I had someone say you can only choose one thing and you're only allowed to do that, I would do the ab stuff. I would do the heavy ab stuff.
Correct. So for example, with my patient, the gentleman with the hEDS, the one that we addressed at the beginning of the discussion, he has very good hip control in hip extension. So even in his deadlift, yes, he was getting really good hip extension, but he just did not have enough counter force to stabilize the spine. So the extensor muscles were coming in to take over because there's no counter force to address that. So yes, he was still using his glutes, but he was also using his low back. In other cases, he has already done a lot of glute work and hip extension, glute dominant hip extension work. So that issue has already been addressed. The main dysfunction, you know, that got exposed at that performance level was this is not working, this is overworking, we made this work and this relaxed, which is the first principle we talked about, reciprocal inhibition. And then it was immediate, you know, relief from, you know, pain.
Yeah, for me, this is the really exciting part, and it's something I think I was quite excited to rediscover it, because this is this is the realm that I used to deal with when I was doing my powerlifting and I was a lot healthier. So then to have this massive downturn where my health got a lot worse, and then to finally get back to the point where it's like, actually what I need now is strength. And I've got something really positive to work on. And it's not just that I'm having trouble with the most basic things anymore. I've got the basics under control. Now I'm getting stronger. And it feels like it's the same problem popping up again, but it's actually a new problem. And now I need strength. And now I need to build ability and capability. And it's sort of like, I think it's quite encouraging because A, it means that it's a sign of progress.
Yep.
But also B, I love getting stronger, and that's the cure. It's like taking the most delicious medicine in the world. It's like, oh yeah, this thing that I love doing is also the fix. So yeah.
Absolutely. And strength, it's at the end of it, I generally do not like to say I'm in the rehab business. I like to say I'm in the resilience business. And what gives us resilience is strength. It's not linear, right? It looks always like a squiggly line, you know, not just for hEDS, but non-hEDS, you know, client as well. But hEDS tend to be a little bit more squiggly than the non-hEDS. But we are in the business of building strength as a skill depending on what we are finding at our assessment, and addressing that and keep getting better at it. And as we are getting better at it, we are going to expose other things, and we find answers for those along the way. But the ideal, you know, end point, which we're never going to get to, but we want to keep managing that to the best we can, it's our ability to strengthen movements and what we need to do at a segmental level or at a complete level to get to that point of strength. And strength, we're both familiar with, you know, Westside Barbell, Louis Simmons. You know, one of my favorite quotes from him: "Weak things break easy."
Yeah, and strength is never a weakness is another one.
Strength is never a weakness. Yeah.
One more thing I'll add, because I'm just conscious of time. This has gone on for quite a while, and your time, but also the viewer's attention span, is. I guess just mentioning that this is probably not going to be the solution for everyone who's got an SIJ subluxation occurring from lifting. I think if you're more in the beginner phases, it's probably, we want to look at technique, we want to look at overall strength, and if you're having a particular exercise that's causing subluxation, as a coach, I would be inclined to say, let's just avoid that exercise. And instead, let's work on building overall strength, stabilizing your mast cells, getting you in a good rhythm, getting you into the point where you actually are, like, I and Shant's client were both through our rehab phase, if you want to call it the rehab phase. It's hard to know where rehab starts and ends with hEDS, but we were through that. I'd been doing 2 years of intensive, frustrating rehab stuff. And then I sort of got to the point where I felt like I was in the clear. You know, I talk about the red zone and the green zone. The red zone is highly inflamed, easily things just going wrong all the time. Any type of progression usually causes inflammation. The green zone is where we actually need progress to feel better.
Yeah.
And that was the point that I was at with my deadlifts. And I'm sure your client was as well, where if we didn't deadlift, we were going to have bad results.
Correct.
But if we did deadlift, this is what happened. So we had to find a way to sort of walk that tightrope. So I guess I just want to say that this will not apply to everyone.
Yeah.
But if you feel like this has resonated with you, it might be something worth considering. Or just understanding the principles that we talked about here.
Yeah. And from a clinician's point of view, what I would suggest clinicians and clients and patients is it starts with good assessment. We need to be very good at assessing because that gives us all the data points that we need to look at. The more precise our assessment is, the more precise our information. The more well-informed we are about our assessment, the more well-informed the intervention approach will be.
Yeah, I should add, I did some actual SIJ assessments on myself when I had the subluxation, and I took it to the doctor and I said, and he pointed and he said, this whole area is really inflamed and, you know, things like that.
We never want to shoot blind.
Yeah.
Yeah.
Awesome. Well, thank you everyone for joining. Thank you, Shant, for joining.
My pleasure.
If you want to book in a session with him, he does online, he does in person in Melbourne. So I'll link his website in the notes below. But thank you everyone for joining.
And also for all your patients, we have an NE100 code, which makes it a lot cheaper for you guys.
Yeah, so if you want to get $100 off, I don't benefit anything from it. But if you use the code ANNIE100, I'll put that in the discussion below as well. It's not for absolutely everyone to use. It's for people with Ehlers-Danlos'er, and you don't have to have a diagnosis, but in this cluster. So yeah, we've just made it more affordable because this population tend to have many things up against us, including finances. So I'll put all the information for that below, but thank you very much for joining. I'll see you in the next one. Bye everyone.